Alright, welcome back. We are on case number 12. A 4-year-old child has been shot in the arm in a drive-by shooting. The site of bleeding has been controlled by local pressure, but he is hypotensive and tachycardic. 2 attempts at starting peripheral IVs have been unsuccessful under the age of 8. 8-year-olds or under will be suitable for getting an excellent circulatory access through what we call as intraosseous. Intraosseous access is one of the best ways to get into a difficult access case of a child under the age of 8. Okay. Now, as far as I have, the note says 6, but I think 8 is also doable. So when I was, it's about 5 years ago, I was on call in my hospital. I'm not a pediatric surgeon. And I had a resident from USC who was a 4th-year resident, a senior resident with me, and they take calls with us, they work with us, they take calls with us. And this resident got a call from a pediatric nurse saying that please come down and get us an IV access on a 6-week-old baby that is in septic shock from urosepsis. Yeah? So, the resident said, well, we don't have experience in putting central lines in, infants. So I was hearing the discussion, I took over and I said, well, this is Dr. Farooqui, what can I do for you? And nurse said, well, we'll need your help here, Dr. Farooqui, we need access to this dying baby. She's 6 weeks old. And I said, 6 weeks old? I've never put a line, I've never put a... I said, what, call the pediatrician. She said, well, the pediatricians are here and they have failed. I said, okay, call the neonatologist. And she said, neonatologists are here and they have failed also. Then I said, okay, what about anesthesia team? So they're all here and they have failed. So basically they had tried everything and the baby was going. So, when nothing works, the go-to person in the hospital is always a general surgeon, right? And you can't figure things out when patients are dying, the general surgeon is on the spot. General surgery, I tell you, general surgery is a very high responsibility job. And you don't get compensated that much, You don't get compensated that much. So anyway, I went and I saw that there was a Hispanic couple waiting outside the room, obviously young couple, their first child, they were very nervous, baby was dying. I went in and I looked at the baby, and the room is surrounded by these so-called specialists and they've all failed. The baby is in front of me, tachycardic and hypotensive and pale in color, and I see the antecubital foci, the back of the hands, even the scalp, the femoral. There was like multiple punctures. And I've been teaching this for many, many years, and I said, okay, in the pediatric age group, we do intraosseous access. Let's try that out. And I asked for intraosseous needle. And the nurse said, we don't have any intraosseous needles. So by the time I'm discussing this and trying to think about it, the baby's eyes are rolling up, she's turning into complete bradycardia. Her heart rate was 150 when I arrived, and then it dropped down to 100, now it's down to 40. Baby's eyes are rolling. You see the baby is dying in front of you. So all I did was take a lumbar puncture needle and went right into the upper third of the tibia, and the moment I went in, I met with some resistance of the periosteum. You just go in. The children's periosteum is very, very soft. You go in and you are in the medullary cavity with frank blood coming out. And I looked at the pediatrician. I said, how much? He said, 250 mils over 20 minutes, half normal saline. I injected that slowly with my own hands, and the infant literally returns back to life in front of my eyes. I'll never forget that. So intraosseous access is really, really helpful when you need it. Do the doctors who were there, didn't they know this rule? Yes, they did. And they even tried, and they met the resistance and they backed off. What does that mean, Francisco? That means that that requires that thing. General, general surgeons have that courage, right? Because the physicians always think, physicians always think that there is something wrong if this is not going easy. Surgeons, realize that sometimes doing, life-saving procedures requires the mentality of contact sports, push your way in. Yeah. So I got in. Within seconds, the child was back to normal. And in fact, that was the only access we could get on this child. But I will never forget the face of that baby, the eyes turning upwards, the bradycardia, the pale color, the couple holding hands and praying. I mean, that was an amazing, amazing moment of my life. And I never did my intraosseous access before or after that, but that one time it saved a life. It's amazing. Alright, so the books say age up to 6, okay, except 6. Although at other places I have read 8. But younger person, younger child, right? Intraosseous. During a wilderness trek, a 22-year-old man is attacked by a bear, bitten repeatedly in the arms and legs. His trek companion manages to kill the bear and to stop the bleeding by applying direct pressure. But when paramedics arrive 1 hour later, they find the patient to be in a state of shock. Transportation to the nearest hospital will take at least 2 hours. So, if the patient has been bleeding and is in a state of fully established shock, and the nearest hospital is not 5 minutes up the road, but 5 hours away, then the paramedics are supposed to then do what they have learned to do, be the heroes as the first responders, put in IV line, give them fluids, dress the wounds, suture the wounds, put the necessary dressing, give fluids, resuscitate, and then bring the patient to the hospital as soon as possible. A 22-year-old gang member arrives in the emergency room with multiple gunshot wounds to the chest and abdomen. He's diaphoretic, pale, cold, shivering, anxious, asking for a blanket and a drink of water. His blood pressure is 60/40, pulse rate is 150, barely perceptible. What kind of shock is this? Is it hemorrhagic shock, cardiogenic shock? It is hemorrhagic shock because we have not mentioned distended neck veins and the patient has gunshot wounds to the chest and abdomen. You need to take him to OR, you need to resuscitate him first in the ER. ER or OR? What are you doing in the ER with a gunshot wound to the abdomen? You see, blunt abdominal trauma is different. Blunt abdominal trauma, you do serial evaluations, quick serial evaluations to find out what's going on. But the rules completely change if it's a gunshot wound to the abdomen. In gunshot wound to the abdomen, whether the patient is dead or alive, patient is stable or unstable, patient is hypertensive or not, they all go to the operating room. Gunshot wounds, no exception, you go to the OR. Okay, so you do your primary survey, ABC, you take the patient to the OR and then you explore. It's hypovolemic shock. A 22-year-old gang member arrives in the emergency room with multiple... By the way, if you have gunshot wound to the chest and abdomen and you are given 5 minutes and 1 X-ray to order, which X-ray would you order? Exactly. Chest X-ray will tell you whether you need to open the chest or not, period. So gunshot wound to the chest and the chest X-ray is normal, forget about it. Focus on the abdomen. If the gunshot wound to the chest shows that patient has pneumothorax, you can put a chest tube as you're moving to the operating room. So chest X-ray is the most needed X-ray of all the X-rays in this case. In a polytrauma victim, what X-rays do you routinely order? Any idea? Chest X-ray is one. Come on, Rahman. Cervical spine. Carla, not the skull, my dear, not the skull. It's cervical spine, chest and pelvis. Cervical spine, chest and pelvis are 3 X-rays you order on all polytrauma victims. So, case number 15, a 22-year-old gang member arrives in the emergency room with multiple gunshot wounds to the chest and abdomen. He's diaphoretic, pale, cold, shivering, anxious, and asking for a blanket and a drink of water. His blood pressure is 60/40. His pulse rate is 150, barely perceptible. He has big distended veins in his neck and forehead. He is breathing okay and has bilateral breath sounds and no tracheal deviation. No tracheal deviation. So what kind of shock is this? This is the cardiogenic shock, and what is the most likely cause of cardiogenic shock when the breath sounds are equal bilaterally. It's cardiac tamponade really, isn't it? So, would you ever order a chest X-ray to rule out tension pneumothorax? Would you ever order a chest X-ray to rule out tension pneumothorax? Would you ever order an echocardiogram to rule out pericardial effusion? Francisco, yes, for what? Echocardiogram to rule out pericardial effusion in cardiogenic shock? Francisco, no, thank you. Yeah, if it's chronic pericardial effusion due to uremia, nephrotic syndrome, or pericarditis, you can order echocardiogram. But in acute cardiogenic shock, it's a true life-threatening emergency. You have 2 or 3 minutes to look at the patient, confirm the diagnosis, and treat it. 2 or 3 minutes. If you don't achieve the diagnosis and treatment within this time, patients usually die from cardiogenic shock. Okay, so now what we have to do is we have to, how do you treat cardiogenic shock from pericardial effusion in a case like case number 15? What's the next step in the management? Pericardial window takes time. Pericardiocentesis. You put a needle in the pericardial space and aspirate blood. How much blood do you need to aspirate? 10 cc's, 20 cc's, 50 cc's, or just as much as is necessary to get the blood pressure above 80? What's the right answer? No, there's no fixed volume. Even 10 cc sometimes makes a difference and the patient's blood pressure comes up. You see, your pericardiocentesis is not the end point of treatment. Pericardiocentesis is the bridging to the ultimate treatment. If you have gunshot wound in the chest and you have cardiac tamponade from pericardial effusion, what's the cause? What's the underlying cause? The underlying cause is a bullet hole in your heart. So the bullet hole in your heart is not treated by pericardiocentesis, it's treated by a thoracotomy in the emergency, in the OR, and repair of the injury in the operating room. But to get to that point with a systolic of 60, what happens at 60? Are you perfusing your brain at 60 systolic? Are you perfusing your myocardium at 60 systolic adequately? Are you perfusing your kidneys at 60 systolic? No. You're barely perfusing your brain, your myocardium, and your kidneys at 60 systolic. You got to convert the figure of 60 to above 70. Okay? And that is why you do pericardiocentesis, just to give you that window to get the patient moved out from the emergency room to the OR and do thoracotomy and fix the hole. But you don't, so it's not a fixed amount that I need to drain 50 or I need to drain 100 or I need to, it's any amount that gets your blood pressure up to 70 or more, then you're moving. Sometimes it takes 5 or 10 cc's to decompress, and that's all that is necessary. Okay? What if you put your needle in and you have a classic triad of cardiac tamponade? What is the classic triad of cardiac tamponade called? It's called Beck's triad. Now who's going to tell me the 3 components of Beck's triad? And by the way, pulsus paradoxus is not one of them. Beck's is hypotension. So hypotension. What else? Beck's triad is hypotension, JVP, muffled heart sounds. These are the 3 things. Distended neck veins, hypotension, muffled heart sounds. Barely audible, Vikram. That's what it means, muffled heart sound. Now, so when you get the Beck's triad and you put a pericardiocentesis needle in the heart and you're trying to aspirate the pericardial effusion and not a drop of blood is being aspirated, what's the diagnosis? Are you wrong? Asma is saying, no, you're not wrong, but what is going on? Neeraj is repeat. Okay, I repeated it again. Wrong space. Okay, I went into the right space under ultrasound guidance. Maria is saying maybe it's tension pneumothorax. No, I swear to God, Beck's stride is classical pericardiocentesis. The trachea is not moved and bilateral breath sounds are equal. Tension pneumothorax is out, Maria. Trust me, it is cardiac effusion. It is pericardial effusion. It is pericardial tamponade. But the blood is coagulated. Chimichurri. There you go, Chimi. And Chimi said it. So you have a needle right into the blood clot and you're going to drain nothing. In fact, when you speak to Dr. Dimitriadis, who is the chief of trauma surgery at Los Angeles County General Hospital, and one of the most experienced trauma surgeons in the world, he'll tell you that 60% of the time, you get the Beck stride, 60% of the time, you get the dry tap from pericardiocentesis. Dry tap. That is because so much blood is there in the pericardial space that it clots. And when it clots, what do you do next? Chimi, help us out since you came up with the idea. Having a TPA infusion takes a while. And you're going to cause TPA infusion just to dissolve the clot, to aspirate. Our patient is bleeding to death. That's not a good idea. Neeraj, blood transfusion? No. Why don't you crack open the chest and do a pericardial window and, if it's a blood clot, you need to make a bigger hole in the heart to get rid of the blood clot, right? So you do a thoracotomy in the emergency room, create a window and basically extrude the blood clot. Once you extrude the blood clot, the heart will start beating, the blood pressure will come up. But by the same token, I don't know why heparin is being discussed here, Francisco. Heparin has no role here. By the same token, by the way, heparin does not dissolve the clot. Heparin prevents further clotting, okay? So you're not going to use heparin in trauma. You're going to crack open the chest right in the emergency room because it's an emergency. Crack open the chest and you basically go into the pericardium and slash it open. The moment you slash it open, blood comes out and the blood pressure comes up. But the problem is wherever the bullet hole is, it's going to start bleeding. So what do you do then? Now you open up the cardiac tamponade because it was compressing on the heart and giving no vital signs. Now you opened up, so the blood pressure is coming back up. What is Kussmaul sore? What does that mean? Kussmaul sore. Kussmaul sore is some kind of a Greek word, is it? Or Russian? So what you really do is you put in a Foley catheter and blow up the balloon right into the heart's hole and lift the balloon up and it tightens against the hole and hopefully you're going to control most of the bleeding, if not all. While you're doing so with a chest open, you take this patient to the operating room. It's pretty dramatic. Okay? So that is important with pericardial tamponade. You see pericardial tamponade, you do a pericardiocentesis. That doesn't work. You crack open the chest and do a pericardial window, and that certainly will work. And then you put in a Foley catheter in the hole of the heart which is bleeding, and take the patient to OR to repair the hole. During a domestic dispute, a young woman is stabbed in the chest with a 6-inch long butcher knife. On arrival at the emergency room, she is found to have an entry wound just to the left of the sternal border at the 4th intercostal space. Her blood pressure is 80 over 50, her pulse rate is 110, and she's cold, pale, and perspiring heavily. She has big distended neck and facial veins, but she is breathing normally and has bilateral breath sounds. What's the diagnosis? Is it a hemorrhagic shock, cardiogenic shock, nervous shock, spinal shock? What kind of? It's cardiogenic shock from cardiac tamponade. Alright, what is the next appropriate step in the management? Number 1, pericardiocentesis. Number 2, take the patient to OR. Number 3, patient should be taken to ICU. Everybody's saying OR. So in the previous case, you are doing pericardiocentesis. In this case, you're taking the patient to OR. What changed? What really changed here, and you're right, you're taking the patient to OR, because the systolic blood pressure is already there, perfusing the brain. Above 70, your brain is perfused, hers is 80. So above 70, your brain is perfused, right? Your myocardium is perfused, right? And your kidneys are perfused. So what's the business of doing pericardiocentesis here? Take the patient to OR and do a thoracotomy and repair the hole. Alright. is if you get a gunshot wound or a stab wound to the heart, is cardiac tamponade better, or rather having a hemothorax from that injury has a better prognosis? Cardiac tamponade has a better prognosis, or hemothorax has a better prognosis from a penetrating chest trauma? Depends. Everything depends. Hemothorax, most people are going to say hemothorax, but Juan is smart. He said it depends, which means he doesn't know the answer. Everybody else is actually wrong. Juan, you are a smart guy. Juliet, a cardiac tamponade doesn't kill you faster, my dear. Actually, if you have hemothorax, it's free blood, free bleeding of the entire myocardial contents into the chest space. And if you have hemothorax after a gunshot wound to the heart, that patient usually will be dead. Okay, so cardiac tamponade gives you that window to save the patient because most of the bleeding is contained and is not free into the chest. If the bleeding is not contained and free into the chest, the patient is going to bleed to death into the chest within a matter of few minutes, and most of the time, by the time they are in the ER, they are already dead. So hemothorax basically means free bleeding inside the chest from a cardiac injury, penetrating trauma. So that's not a good thing. So if you see a big, huge, large hemothorax, as you open the chest to save the life, you're basically doing an autopsy. That's what I'm trying to say. Cardiac tamponades the bleeding, so the blood remains in the circulation, although not moving as well as it should, but gives you an opportunity to save life. Just a conceptual understanding of the injuries. And I knew you were going to say that hemothorax, but I tell you, cardiac tamponade, as dramatically obstructive and life-threatening as it may be, actually is a better deal. Okay? So we hope that we all have a very strong pericardial layer, so that when there is a penetrating trauma to our patients, those pericardial layers are protected. Alright, moving on then to case number 17. A 22-year-old gang member arrives in the emergency room with multiple gunshot wounds to the chest and abdomen. He has labored breathing and is cyanotic, diaphoretic, cold and shivering. His blood pressure is 60/40, pulse rate is 150 and barely perceptible. He is in respiratory distress and has big distended veins in his neck and forehead. His trachea is deviated to the left and the right side of the chest is hyper-resonant to percussion with no breath sounds. What kind of shock is this? Is it hemorrhagic shock, cardiogenic shock, or neurogenic shock? Obviously, it is cardiogenic shock secondary to tension pneumothorax. How do we know that without ordering a chest X-ray? We know that because the trachea is deviated in absence of breath sounds on one side. What is the next appropriate step in the management of this patient's condition? Number 1, secure the airway. Number 2, take the patient to OR. Number 3, put in a chest tube in the 5th intercostal space. And number 5, put in a large bore IV cannula in the 2nd intercostal space. And number 6, order a chest X-ray. Chimichurri, tell me what is 5, Chimi? I don't know what does that mean. I don't remember my order. It just descends and comes out, you know. Yeah, Rahman, you're right. The 2nd intercostal space needle decompression takes about a second to do. That's the easiest answer. Yes, Chimi. Big needle, 2nd intercostal space, mid-clavicular line, and you hear once you hear the swishing sound, the pressure will come back up. You have all the time to put the chest tube in. I'm not saying chest tube is wrong answer. What I'm saying is chest tube is time consuming and you have a guy who's about to die. So you don't have, it takes about 5 to 10 minutes to put in a chest tube. And you want to relieve this and make the chest tube insertion not a life-threatening situation, but you just put in a needle, decompress, let the pneumothorax be a simple pneumothorax. The moment you put in a needle, you convert a tension pneumothorax into a simple pneumothorax. Once you have a simple pneumothorax, you can be smoking cigar with one hand and putting the chest tube with another at the same time. You have all the time. Don't do that. It's an example. But you have all the time to put in a chest tube. You can put the paint on the chest wall, betadine paint, let it dry, inform the patient what you're doing. A needle is coming now. and the needle will go in and numb the area. Then you put a little skin incision. Then you put the blunt, Kelly to split the muscle fibers. Then you go puncture the pleural space. You hear, and then you put in a chest tube guiding upwards. That's it. Take your time. Do it nicely. Just convert it. Don't want to smoke in front of the patient. That's right, Juan. Duh. It was a joke, buddy. Didn't you get it? Chest tubes always go asthma in the fifth intercostal space. There was a time. It all depends on who you're. You're just laughing. So it all depends on who your professors are, right? I mean, if the professors were trained in the 50s and the 60s, they would always tell you to put your chest tube for pneumothorax in the second intercostal space because the air rises, and put your pleural effusion and pneumothorax chest tubes in the basal spaces. But that is all gone, and basically what you do is put in a chest tube. Whether it's hemothorax, pneumothorax, and pneumothorax, it doesn't matter. The chest tube goes in one place in the United States of America in 2014, and that is anterior axillary line, fifth intercostal space. And where is your fifth intercostal space, Juan? What is the surface marking for fifth intercostal space? Are you going to start counting? Juan? Apex? Apex is fifth intercostal space in the apex, you silly. Yes, it's the nipple. Yeah, but Juan was shy, so he didn't want to touch the nipple. But that's where it is. The fifth intercostal space is any space next to the nipple is the fifth. So go into the anti-axillary line and insert the chest tube through that. That is the landmass. Fourth, no, it's fifth actually, Asma. Usually most chest tubes are inserted in the fifth intercostal space. Nipple signifies fifth intercostal space, at least in this country. You know. Alright, so the second intercostal space insertion for chest tubes is out. However, if you're going to put a Heimlich valve, check the spelling, but I think that's how Heimlich valve. Then check the spelling. I'm not sure about the spelling of Heimlich, but you know what I mean. Heimlich valve needs to go into the second intercostal space mid-clavicular line. And asthma, if I give you a patient who has 40% pneumothorax in a stable condition, he develops spontaneous pneumothorax. So it's a case of internal medicine. Patient arrived in the emergency room with sudden onset of shortness of breath and chest pain. He's 20 years old, tall and lanky. You do a chest X-ray, you see a 40% pneumothorax. How do you treat that? Heimlich valve, my friends. No need to put in a chest tube. Why? Heimlich valve will allow the escape of air but not air entering back. And that's the best way. It's comfortable for the patients. They can go home from the ER. Am I right? Oh, it was. Hang on. Thank you, Ivy. Let me correct this, my dear. Let me correct this. What am I doing here? So, let's do it again. H-E. This is a German name. Heimlich valve. Anyway, so Heimlich valve needs to be placed in the second intercostal space, and it's basically a, like you put a central line. It's exactly the same technique. Seldinger technique. You puncture into the second intercostal space, you put the guide wire into the pleural space, and then you put a dilator over the guide wire, and then you put the valve with the catheter over the guide wire, take the guide wire out, and the catheter is connected to the valve. You stitch the catheter to the chest wall, put some dressings on, get a chest X-ray. The lungs get fully expanded after a few hours. They go home. You don't need to keep them in house. Chest tubes will have to be admitted to the hospital. And in this day and age, just because of simple spontaneous pneumothorax, we don't admit the patients. They go home with the valve. They come back and see a chest surgeon a few days later. They get a chest X-ray. If it's fully expanded, they take the Heimlich valve out. Story is over. It is done. What's the most common cause of spontaneous pneumothorax in the community? Most common cause spontaneous is ruptured blebs or bullae. That's right. And sometimes and how does the pneumothorax stops leaking air? What is the magic? emphysema, ruptured blebs, or bully. What converts the pneumothorax into no pneumothorax and perfectly healed lung? What is the mechanism? What is the pathology, pathogenesis of resolution of pneumothorax, which means the hole in the lung is covered. Flap closes, negative pressure. What do you mean by flap closes, Abney? Absorption of air? No. Asma is saying one-way valve? No. Negative pressure? No. Absorption? No. It's drainage of air. It's not absorption, by the way. You're putting a Heimlich valve or a chest tube, it drains the air out. The word I'm looking for, the word that describes the healing, unless you know these things, you won't understand why things are happening. Re-expansion of the lung. Now look at this, ladies and gentlemen. Pleurals, parietal pleura is out to the periphery. Lung is collapsed. Pneumothorax, air everywhere. You have a hole or an injury in the lung parenchyma, leaking air. This will stay like this forever and ever and ever till you drain the air from the pleural space and re-expand the lung. Once the re-expansion takes place, my friends, the lung re-expands and the hole gets covered by the parietal pleura, and that is your natural dressing. It's the kiss of the lovers, Let the lung touch its lover, the parietal pleura. Let them kiss. That's the healing. You understand? Think like a poet sometimes. It helps. Okay? Remember things. So, it's that approximation of the very romantic. That's right, Carol. That's right, yes. I'm a romantic man. So, when you have expansion of the lung, it touches the parietal pleura, and once you get that union back, no leakage. It's your internal dressing. So, that's the idea behind it. Alright, moving on then from tension pneumothorax. So, you understand if they are going to give you, yes, it seals, Mariana. When they're going to give you a case of tension pneumothorax, they're going to give you choices. One of the choices will be X-rays, don't choose it. Another choice will be chest tube, wait, it's a very good candidate. But the third choice is needle decompression. If they're asking you for next step in tension pneumothorax, needle decompression first, chest tube second. Okay, just remember it always. Never order a chest X-ray. Okay, moving on to case number 18. A 22-year-old man is involved in a high-speed head-on automobile collision. He arrives in the emergency with fixed dilated pupils. He has multiple obvious fractures in both upper extremities and in the right lower leg. His blood pressure is 70/50 with a barely perceptible pulse rate of 140. His central venous pressure is 0. Fixed dilated pupils, in coma, obvious fractures of both upper and lower extremities, hypotensive, tachycardic, unconscious. What is the next appropriate step in the management of this patient's condition? Number 1, X-ray of the skull. Number 2, CT scan. Number 3, 2 large bore IV cannulas. Number 4, take the patient to OR for craniotomy. Two large bore IV cannulas. Vikram, no. You're not going to take this patient who is hypotensive, tachycardic, unconscious, with no airway control, with no IV access to CAT scan. You're not going to take anybody like that to CAT scan. Remember that, Vikram, Asma, Natalie. No CAT scan, boys and girls. No CAT scan, okay, children? Always remember the CAT scan is after things are stable and under control. You should have the airway under control. You should have IV access. And I told you A, B, and C. Look for A, B, and C. If I have not given you A, and if I have not given you B, but I have given you C, choose that. I'm just testing you guys. Okay? But if airway was there, you would have chosen airway. Unconscious patients. So unconscious patients with no control of airway or IV access, how can you go to the CT scan? You can't go to the CT scan. Now he's hypotensive. He's hypotensive, so he's bleeding somewhere, right? Where is he bleeding? Is he bleeding in the brain? That could the hemorrhage in the brain? I mean, he definitely has intracranial bleeding. You can see it. He's in coma. He has that fixed dilated pupils. He's intracranial injury. Is that the cause of his hypertension? Can intracranial bleed cause hypertension? Never, 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 never. So he's bleeding somewhere else. Now here things are getting interesting. If the guy comes to you in the emergency room in coma, and you know for sure he has lateralizing sign, dilated pupil, non-responsive, and you also have hypertension, and you figure out that his hypertension is not getting corrected by the methods I have taught you, rapidly giving fluids, rapidly checking H&H, rapidly checking vital signs, and the guy is not getting better, what do? Where do you go? Where do you go? Is he stable enough to go for a CAT scan? No. He needs to go to the OR. So if he's going to the OR, who gets the first cut? The neurosurgeon or a general surgeon? Who gets the first cut? Neurosurgeon, in the name of God Almighty. He's going to die from a ruptured, blown spleen first, or is he going to die from an intracranial bleed first? Think about it. A ruptured spleen that is bleeding and is not responding to your initial resuscitation. You have decided he's hypotensive in spite of 2 liters or 1 liter given. Now one is you're changing you're turning the tables around for me. You're a general surgeon. Who's the king of trauma, Juan? Who is the king of trauma? General surgeon. So always remember, ruptured spleen versus intracranial bleed versus dissecting thoracic aneurysm. Neurosurgeon gets to go first, thoracic surgeon gets to go first, or a general surgeon gets to go first. If you're the trauma is all about triage, right? Priorities first. What kind of hemorrhage will kill the patient first is the open free bleeding from a ruptured spleen. So general surgeon goes in first. That is why the general surgeons are the kings of trauma. Period. Okay. After the intra-abdominal bleeding is controlled, then you can go inside the cranium. And what kind of treatment would you do for an intracranial hematoma? Choices are burr hole, craniotomy. Which one is the best answer? Avni, Ivy, Asma, burr hole. My God, you guys are living in the 21st century, or you're living in the 19th century? Nobody does burr holes anymore. Where you guys, it's craniotomy, guys. Nobody does burr holes. Please, burr hole is only mentioned because it's of historical importance only. Burr holes and burr hole drills belong to the museums of surgery. They are not in current use. But that's quick. Craniotomy is as quick, my dear. You don't need to do burr hole. Burr holes are incomplete evacuation. Burr holes cause trauma. Burr holes are uncontrolled. Burr holes are for burr holes, BH. Burr holes are for buffoons. Real thing is to do a craniotomy, flip the skull open, and take out the clot, and then close the craniotomy, or not, based upon how bad the injury is, Because that congresswoman who was shot in the head at point blank distance in Arizona, she was treated with a craniotomy, and they took the cranium out, and then they didn't put the cranium back for about 15 days. They took her cranium and wrapped it in saline gauze and put it in the refrigerator for 15 days while she was recovering, because her brain was allowed to expand. Otherwise, the brain would have had irrevocable damage. So in the United States, we do things which are outside the box. We try our best to save our patients, and that woman is alive and functional. At least 60–70% brain is functional. She can think, she can talk, she kind of lisps a lot, but she can talk, she's functional, and she's alive. I can tell you anywhere else she would have been dead or permanently impaired to the degree that she could be non-functional. But she's alive and functional, It's pretty impressive, you're right, Rohini. So the craniotomy is the right answer for intracranial bleeding. But in this guy, the hypotension should not be blamed on intracranial bleeding. Hypotension is almost always due to free intra-abdominal hemorrhage. Moving on then to case number 19. Now we are taking a brief detour from trauma setting. A 72-year-old man who lives alone calls for 911 saying that he has severe chest pain. He cannot give a coherent history when picked up by the EMTs, and on arrival at the emergency room he is cold and diaphoretic and his blood pressure is 80/65. He has irregular feeble pulse at a rate of 130. His neck and forehead veins are distended and he's short of breath. Now this is a cardiogenic shock with distended neck veins, but it is in a non-trauma setting, which means it's an elderly gentleman who has probably experienced a huge myocardial infarction. And when you have a huge myocardial infarction, you can go into a cardiogenic shock, and that can lead to problems, right? So you know the best treatment for myocardial infarction, and that's what you're going to do. Case number 20. A 17-year-old girl is stung many times by a swarm of bees. On arrival to the emergency room, she has a blood pressure of 75/20 and a pulse rate is 150, but she looks warm and flushed rather than pale and cold. CVP is low. Bee sting, anaphylactic shock. What is the next appropriate step in the management of this patient's condition? Number 1, airway. Number 2, epinephrine. Number 3, IV access. The best answer is you're given epinephrine. Why do you choose epinephrine over airway? Why do you think epinephrine is better than airway here? Simple reason. There are two things going on: the bronchospasm and bronchial edema. And when you are thinking about airway, the bronchospasm, bronchoedema is there already, and getting the tube through that is going to be impossible. Epinephrine will cause bronchospasm to reverse, epinephrine will cause bronchial edema to reverse, and epinephrine will also bring the blood pressure up. So you're killing 2 or 3 birds with one stone. Epi injection is the key here. 20 minutes after receiving a penicillin injection, a man breaks into hives and develops wheezing. On arrival at the emergency room, his blood pressure is 75/20 and his pulse rate is 150, but he looks warm and flushed rather than pale and cold. His CVP is low. Again, it's an example of anaphylactic shock to penicillin, and the treatment remains the same. In preparation for an inguinal hernia repair, a patient has spinal anesthetic placed. His level of sensory block is much higher than anticipated, and shortly thereafter his blood pressure drops to 75/20. But he looks warm and flushed rather than pale and cold. His CVP is low. This is an example of neurogenic or vasomotor shock. It has happened because you've given a spinal anesthetic too much dosage, which has traveled upwards. The more the spinal anesthetic travels upwards, the more sympathetic outflow is blocked, and the more the chances of hypotension. And this is the kind of shock which is produced by basically neurogenic mechanisms. Treatment for this would be, number 1, you have to elevate the head of the patient. Number 2, IV access and fluids and vasoconstrictors like Levophed. Okay. Alright, we're going to stop here for 10 minutes and come back and start the review from head to toe. Maybe we'll see some pictures. Alright, welcome back from the break. I just want to show you the slides that we have related to our first 3 hours of discussion. This is an example of orotracheal intubation that we were talking about. It's the most common way of accessing airway for patients who are unconscious. And of course, it's a standard way of securing airways in people who are undergoing anesthesia as well. This is an example of pericardial tamponade. This is an example of actually what condition? You can see the tension pneumothorax. You can see the tracheal aerogram. You see the trachea is shifted, and you also see the collapsed lung border right there. And this is a tension pneumothorax based upon the, I suppose, based upon the vital signs which will be shown. What is the error in this scenario? What is the error in this scenario? They did a chest X-ray, yes, absolutely. So if you see a chest X-ray of tension pneumothorax, I think the guy who ordered it must have been a buffoon. But anyway, this was ordered, and this is here. We captured it for your pleasure. You can see this. But really, the diagnosis of tension pneumothorax is clinical. No, there is no chest tube placed as yet, not that I can see. What we need next is what? A chest tube? Needle decompression, that's right. Alright, Dr. Amal, let's move on and see some other of your goodies. Head trauma we are going to do later on, right? Okay, so I think the initial pictures that we did were pretty good at that point. Now we're going to go to the whiteboard, and we're going to start off from head to toe, and then we can show you head trauma. Okay, leave it, actually leave it right there, Dr. Amal, leave it right there. I'm right there on head trauma, so let's go back to the same. Yep. An 18-year-old man arrives in the emergency room with an axe firmly implanted into his head. It is clear that he has sustained an intracranial wound. He is awake and alert and hemodynamically stable. What is the point of this vignette? When you get an impaled object, the idea about taking the impaled object out in the emergency room is rather tempting to all our students. You got an axe implanted into the head, you want to take it out. You got a dagger implanted into the heart, and it's moving with each heartbeat like that. You want to take it out. But the natural tendency of trying to take it out in the emergency room is actually the wrong thing to do, because what happens if you take it out, the patient is going to bleed and die. So it's a good direct, you're absolutely right, Ivy, it's a good direct compression. I remember a case, I used to, one of my favorite programs used to be ER, and it was a program written by Mike Crichton, because he was a surgeon, he was a doctor, and he wrote with medical accuracy. And one of the episodes was about a guy who wanted to kill himself, and he ran into a stake, and the stake was, he was brought by the he ran into a stake and didn't die. So he was brought by the paramedics with the stake impaled into his abdomen, sticking out from the back actually. And when he was brought down to the emergency room, they showed that the professor in the emergency room was teaching a resident, and as he was teaching a resident, the guy was awake and alert and oriented, and he wasn't dead, and he had the stake implanted and really wanted to kill himself. And the professor said to the resident, he said, well, when patients come with attempted suicides and they have impaled objects in them, please never remove them in the emergency room. Because if you remove in the emergency room, they will die very rapidly because the tamponade will be lost. It should be done in the controlled circumstances of the operating room, And as we are waiting for our trauma surgeon to arrive, we are going to save his life. While they are talking to each other, the patient is listening, and the next thing what the patient does is takes it out, and within a second he is dead. Moral of the story is don't talk in front of your patients. That's a funny case. Do you have a picture of an axe implanted into the head of somebody, Dr. Amal? No? Maybe not. So let's move on. Let's see case number 2. In the course of mugging, a man is hit over the head with a blunt instrument. He has a scalp laceration and a CT scan shows an underlying linear skull fracture. He is neurologically intact and gives no history of having lost consciousness. In contrast, in the course of a mugging, a man is hit over the head with a blunt instrument. He has a scalp laceration and the CAT scan shows an underlying comminuted depressed skull fracture. He is neurologically intact and gives no history of having lost consciousness. So, the point of this vignette, now let me get to the whiteboard. Okay, hang on, let's see. I have a helping hand. Oh my God, what is that? That's from a scary movie. I cannot sleep with that picture, but that's an impaled object. Seems like the victim is already gone. She's rather pretty. Alright, so, thank you, Juan. You're so nice. Alright, so this is the skull fracture that we talked about. There's a linear skull fracture, which means the fracture runs like that. And then there is a depressed skull fracture, which means the plate has been depressed like that. So, the treatment of a linear skull fracture is nothing. Okay, is he showing us another one? Let's see. Oh, that's nice. Wow, look at that. Stab into the skull. Juan, you're a really violent man. Where did you get all these pictures from? So stab into the head. Look at that. So never remove any one of these. Can you all see this? That's nice. Look at that hook into the head. Oh my God. Ah, I think you should donate some of these pictures to us. Okay, that's all. It's very gory. What a man. There you go. Alright, thank you for that. Who was that wonderful person who found this out? Rohini. Oh man, those were horrible pictures, right? Alright, so the difference between a linear and the depressed skull fracture is the linear skull fracture can be treated without surgery. You can let the patient go home as long as the patient doesn't have any neurological problems. But what happens to the depressed skull fracture? How do you treat that? Depressed skull fracture needs to go to the operating room, and you need to literally lift this depressed fracture up back into its original spot. See that? Why do you need to do that? And this means obviously you need to go to the OR for this. Why do you need to do that? Any idea? That is, it compresses. Brain structures are compressed. No, I mean the brain structures are compressed is not the reason. Give it a space to breathe is not the reason. Can lacerate vessels. They've already been lacerated. If they've traumatized the brain, they've already been traumatized. You're lifting it back up is not going to make any difference. It'll damage the brain. If the brain damage has to happen, it has already happened. So lifting it back up won't cause it. Entry of bacteria, chimichurri, you're absolutely right, my friend. Ivy is concerned about cosmetics. Who cares? It's actually meningitis, bacterial meningitis. If you do not lift the plate back up, there's a high risk of, there's a very high risk of bacterial meningitis. And Juan, well, chimichurri, you have got a fan here in Juan. He likes chimichurris. Okay. So you got to lift the plate up so it reduces the incidence of meningitis. That is the only reason that you need to remember. Okay, getting back to our vignettes again, Dr. Amal. Is Chimi a lady's name or a gentleman's name? Lady, okay. If it was a male one, it wouldn't have mattered here because, you know, I live in Hollywood, everything goes here, alright. Okay, so a pedestrian is hit by a car and brought to the emergency room. He has minor bruises and lacerations but is otherwise quite well, with a completely normal neurological exam. However, the ambulance crew reports that he was unconscious at the site, and although he woke up during the ambulance ride and is now completely lucid, he does not remember how the accident happened. When it comes to head injuries, guys, the board will often ask you what are the indications for a CAT scan after a head injury. So the indications for a CAT scan after a head injury includes 4 things. Who's going to narrate them? Number 1, his loss of consciousness, retrograde amnesia, lateralizing neurological signs. 3, I think, that's all. So loss of consciousness, retrograde amnesia, lateralizing neurological signs. Just remember these. So in this case, is there a loss of consciousness? Is there neurological signs? No. The only thing that they are telling us is that he does not remember what happened. So retrograde amnesia is another indication for CT scan. Why is it important? Because if you don't have these signs, chances of having a real intracranial injury requiring surgical intervention is very, very low. So in the patient like this, if you have retrograde amnesia or LOC or lateralizing sign, getting a CAT scan will most likely show you something that may require intervention or at least hospital observation. In the past, we didn't have CAT scans, so we used to admit all these patients and observe them in hospital for 48 to 72 hours. It was costly, but now with the CAT scan, patients come in. If that's the only problem, they get a CAT scan. If CAT scan is normal, they're discharged home. Alright, moving on to the next case then. Alright, this is an example of an epidural hematoma. A head trauma with loss of consciousness requires a CAT scan. It will show you intracranial hematomas, neurologically intact, patients with negative CAT scan discharged home, but monitored in case they go into coma. Okay, and a pedestrian is hit by a car. He arrives in the emergency room in coma. He has ecchymosis around both eyes. A pedestrian is hit by a car. He arrives in the emergency room in coma. He has clear fluid dripping out from his nose. A pedestrian is hit by a car. He arrives in the ER in coma. He has clear fluid dripping from his ears. A pedestrian is hit by a car. He arrives in the emergency room in coma, and he has ecchymosis behind both ears, behind the ears. So what are these 5, 6, 7, and 8 examples of? These are examples of base of the skull fracture. So again, base of the skull fracture is a radiological diagnosis or a clinical diagnosis. If you see any one of these, you have base of the skull fracture. Even if you can't see it, it's a base of the skull fracture. So you're right. Base of the skull fracture is a clinical diagnosis, not a radiological diagnosis really, because unless it is displaced, you can't see it. So if I'm giving you examples of the base of the skull fracture and it doesn't mean anything in terms of intracranial injuries, why are we focusing on the base of the skull fracture? What's the big deal? The big deal is that it's a surrogate marker for a true serious injury in the neck. So if you have base of the skull fracture, the force is on the neck, and these patients, you got to be very, very careful. I mean, you have to be very, very careful on all patients with cervical spine injury, but the base of the skull fracture just increases the suspicion for cervical spine injury that much higher. Okay, so you must always do a CAT scan, not just for the skull fracture diagnosis, but for cervical spine injuries. A 14-year-old boy is hit over the side of the head with a baseball bat. He loses consciousness for a few minutes but recovers promptly and continues to play. 1 hour later, he is found unconscious in the locker room. His right pupil is fixed and dilated, and there are signs of contralateral hemiparesis. What is that? That's an epidural hematoma. So you can see the picture of acute epidural hematoma. It is biconvex lens shape and it results in lucid interval. It's a classical injury. It's associated with the fracture of the parietal bone. And what kind of artery bleeds to give rise to epidural hematoma? Meningeal. There are 3 meningeal arteries. Middle meningeal artery is classically involved. So middle meningeal artery bleed, parietal bone fracture leading to epidural hematoma, which is classically presents itself with lucid interval. And what is the prognosis of acute epidural hematoma? Prognosis is excellent. Julieta, it's excellent, my dear. What's going on with you guys? You identify it, you take the patient to OR, you do a craniotomy, and you remove the hematoma. That's it. End of the story. You're fine. It's a very local injury. It's not a global injury. The only time the prognosis is poor is if you delay the craniotomy. You know, if you delay the craniotomy, the bleeding will continue and will cause medulla oblongata to go through, herniate through the foramen of magnum, and then all your vital centers will collapse. This happened to a very famous actress, what's her name? Natasha Richardson, who happened to be the wife of Liam Neeson. And she was in the Rockies, Canadian Rockies, learning how to do skiing, and she had a ground level fall, and she developed, she was only 42. She developed an epidural hematoma. Nobody knew about it, but she had loss of consciousness and she had severe headaches. She was advised to go to the hospital. She refused. And then after 3 or 4 hours passed, she developed severe headaches and finally agreed to go to the hospital. They did a CAT scan, found out an epidural hematoma. And the doctors there out in the boonies, they said we can do a we can do a burr holing. She decided not to get the burr holing. She wanted to be airlifted from the Canadian Community Hospital to City Hospital in New York. By the time the patient came to New York on the helipad, she just coded and died, unfortunately. So prognosis is bad if you delay the treatment. But if you do a timely intervention and do a decompression by cranial, subdural doesn't have an excellent prognosis. What does? Subdural? I'll read about subdural momentarily. So case number 10, a 32-year-old man is involved in a head-on high-speed automobile collision. He's unconscious at the site, regains consciousness briefly during the ambulance ride, and arrives at the emergency room in deep coma with fixed dilated right pupil and contralateral hemiparesis. In contrast, a man involved in a high-speed head-on automobile collision is in coma. He has never had any lateralizing signs, and CAT scan shows a small crescent-shaped hematoma, but there is no deviation of the midline structures. Case 10 and 11 are examples of what kind of a hematoma? Case 10 and 11 are examples of what we call a subdural hematoma, which is a crescent-shaped hematoma that you can see out here, guys. It is a crescent-shaped hematoma. You can see it's in the periphery. It's causing compression of the brain because you see the midline structures are shifting in contralateral direction, and the patient actually has contralateral signs in the case number 10, but not in case number 11. Now, is subdural hematoma, acute subdural hematoma, a representation of a very focused injury, or it's a representation of a global injury to the brain? Because epidural is definitely baseball bat, right there. It's a focused injury, right? But this one, the subdural road traffic accident, head-on collision, it's a global injury to the brain. It's a global injury. So subdural hematomas have guarded prognosis. Epidurals have excellent prognosis. You understand? So when you have subdural hematoma, the one that is causing midline shift, the one that is presenting with neurological deficits, lateralizing, you can do a craniotomy. But the one that presents with non-lateralizing signs and symptoms, and the CAT scan doesn't show any midline shift, would you do a craniotomy in those cases? Asma is saying yes. Why, my dear? You don't. So if the midline shift is not there, even if there is blood present, the midline shift is not there, craniotomies are not necessary. They are only necessary for midline shift or lateralizing symptoms. Now, what are you going to do about the management of patients that are not presenting with midline shift? Well, let's see. A patient involved in a head-on high-speed automobile collision arrives in the emergency room in deep coma with bilateral fixed dilated pupils. CAT scan of the head shows diffuse blurring of the gray-white mass interface and multiple small punctate hemorrhages. There is no single large hematoma or displacement of the midline structures. What is happening here, guys? Let's get the whiteboard here, Dr. Amal. So how do we take care of these patients? Well, patients who have brain injury with no midline shift, how do you manage them? So, management are intubate, obviously they are in coma, with PCO2 between 33 to 35. Number 2, head elevation. Number 3, mannitol. Number 4, judicious IV fluids. Number 5, is steroids. Number 6 is induced complete coma with benzodiazepines. And number 7 is hypothermia. Okay, let me show you this. So when you have brain injury with no midline shift, how do you treat those patients? Expectantly, supportively. And what you're doing is, because there is no midline shift, there's no point in doing surgery, because surgery will compound the edema. What you're trying to maintain here is cerebral perfusion pressure, cerebral perfusion pressure, by keeping intracranial pressure down. That's the key here, guys. You're trying to maintain the cerebral perfusion pressure by keeping the intracranial pressure down. When you have brain injury, brain trauma, the intracranial pressure tends to rise. Intracranial pressure tends to rise because every time any part of the body gets injured, the injury response is by inflammation and edema and swelling. And when you have inflammation, edema and swelling, it's going to compromise the perfusion of the brain. And when the brain perfusion is compromised, it is going to compound the original injury with the secondary injury. Okay. Now what we need to do is to prevent the secondary injury from happening, which means we have to keep the cerebral perfusion pressure up by keeping the intracranial pressure down. How do you do that? Well, intubate the patient and do controlled hyperventilation, not rapid hyperventilation, but controlled hyperventilation. Controlled hyperventilation means you're going to bring the partial pressure of carbon dioxide down from 38 to between 33 to 35, just slightly. If you overdo it, what happens? Francisco, tell me the effects of hypercarbia to the cerebral vasculature. The cerebral vasculature undergo constriction in response to hypercarbia or undergoes dilatation in response to hypercarbia? Constriction. Okay, when the cerebral vessels constrict, Natalia, the intracranial pressure goes up or down? It reduces, right? But if the cerebral perfusion, if your hypercarbia continues to go into severe levels, the vasoconstriction in the vasculature of the brain will be so deep that you will develop perfusion deficits. So hyperventilation is a double-edged sword. On one hand, it causes vasoconstriction and reduces edema, which is good. But on the other hand, it can cause vasoconstriction and produce cerebral perfusion pressure deficits. So it's a double-edged sword. So you want vasoconstriction, but not too much. And the best value achieved for ideal vasoconstriction is maintaining the partial pressure of carbon dioxide between 33 and 35. People used to take the partial pressure of carbon dioxide below 30 and the patients will develop secondary damage to the brain. That is why you can hyperventilate, but you should not go below 33 pCO2. That's number one. So intubate, hyperventilate, but pCO2 should not be below 33. Number two, head elevation is obvious. You elevate the head, the pressure in the brain goes down. Number three, mannitol, so it sucks out extra fluid and gets rid of it and reduces edema. Number four, judicious use of IV fluids. Normal maintenance fluid for an adult is 120 mils per hour, but in a brain injured patient, you're going to give it like 50 cc's an hour. Keep these patients relatively dry, but not hypotensive. Remember, if the volume goes down too much, they will develop perfusion deficiency. Steroids are controversial, but have been shown to reduce intracranial pressure by reducing inflammatory response from trauma. And then finally, if the patient is semi-comatose, make sure the patient is completely comatose. You do an EEG and there should be a flat line, meaning you put the neurons to deep sleep so that when the neurons are sleeping and they are resting, they don't have any metabolic demands, which means they can make do with little amount of oxygen, and this allows them to heal, okay? And the latest and the greatest technology is hypothermia. If the patient is really in deep coma with serious injury, if you drop their core body temperature to 34 or less, you're going to have a very resting and peaceful brain, which will hardly have any metabolic requirements, and this is the best way to allow the neurons to heal, you know. So these are the steps of managing intracranial hypertension from brain injury, where you cannot really do surgery because there's no need for doing surgery because there's no midline shift or lateralizing neurological signs. Alright, so that's a board question, guys, and they ask you that. Now we're going to move forward. We're going to come back to our how do we detect intracranial pressure? Well, we detect intracranial pressure sometimes by creating transducer that goes through the skull. You have to burr it. You have to point it into the brain directly, and that neurosurgeons do that, and you shouldn't try to do that. Okay. If pCO2 goes below, asthma below 30, what happens? The vasoconstriction gets so severe that the patient's reduced, the cerebral perfusion pressure goes down. All right, Dr. Amal, can I go back to the slides now? Okay, so we said there's no midline deficit, so there's no need. A 77-year-old man becomes senile over a period of 3 to 4 weeks. He used to be active and managed all of his financial affairs. Now he stares at the wall, barely talks and sleeps most of the day. His doctor recalls that he fell from a horse about a week before the mental changes begin. Now that's a good event to remember, but sometimes the events are so trivial, nobody in the family remembers what happened to the old man. Maybe he was up in the attic, he was cleaning up his attic and he hit his head against the crossbar